All right, good evening, everyone, and welcome to the program Your Health 360. My name is Jacqueline Adebija. Happy Children's Day. At least I'm getting my chance to say it to you today. Happy Children's Day for every child out there. Children are a blessing. I don't think there's any culture where you find that children are not regarded as blessings, which is why it gives me great pleasure to welcome to the studio someone who is fast becoming an in-house gynecologist, in-house resource person to us here. I'm talking about Dr. Selma Yahaya. Dr. Selma Yahaya is the resident gynecologist at NISA Fertility Clinic, and we're going to be talking about NISA, the clinic itself, and a lot of things that it's done recently. NISA, for a lot of people who know, has its head office in Abuja, and it's been there for quite a while. NISA has over 1,000 babies. Actually, if you're going to take a look at, from inception, they have over 1,000 babies to their record success rate for them. And then to have NISA here in Kaduna, it's exciting because I'm hearing really exciting things, triplets, twins, and so much going on at NISA Fertility Clinic. But today we're going to be talking about the issues around, IVF or fertility as a whole. We're going to be taking a look at that. And of course, the challenges, the factors, and the solutions, because what is a problem without solutions? We want to have solutions here. And so, yes, if you are listening and you're one of those people who have been hoping and praying for a child, please listen and send in your questions if you have any, so that we can start to actively ask questions from you. And that's why I'm asking you to send your text messages or WhatsApp messages to the number 09072703270, so that I can take your questions and ask Dr. Selma in real time. Once again, that number is 09072703270. You can find it on WhatsApp too. Dr. Selma, great to have you with us in the studio. You're welcome.
Thank you very much, Jackie. It's always a pleasure.
Always a pleasure to have you, Dr. Selma. Always a pleasure. So let's talk about fertility.
Okay.
At what point, we always ask you this question, but I think there's no better place to start from. And that is, at what point should a couple start to get worried that, look, there's a problem?
Okay. Hello, viewers. Or listeners, rather.
It's viewers and listeners now, all the same.
Good evening and happy Children's Day to our 50 babies that have been, born through the help of NISA Hospital, Kaduna.
Wow.
Well, if a couple is living together, for a year, they have been having unprotected intercourse, regular intercourse, that means 2 to 3 episodes a week. Not a day, a week. So let's say every 2 days they have intercourse, and they've done this for a year and they haven't achieved a pregnancy, then they should go for some fertility checks.
For a year?
Yes, for a year.
366 days.
However, there's a little caveat.
Okay.
If the woman is 35 years and above, they don't have to wait for a full year. If she has not achieved a pregnancy within 3 to 6 months, then she should, seek the assistance of a fertility facility.
Oh, really?
Yes.
Once she's 35?
Yes.
Why is that?
Because the fertility indices for a woman starts going down from age 35, okay? The reserve of her eggs starts going down. The chances of getting pregnant naturally reduces. Okay, so in such a woman, if there is a problem, then we need to start tackling it to assist her achieve pregnancy, before she gets to the menopause. So the woman's age is important. So for example, you're getting married at 35, especially if you've never had a child before, you don't have to wait the full 1 year, before you start having fertility checks. And remember, I said that if you're waiting the full 1 year, this is a couple that live together. You know, sadly, a lot of marriages, couples live apart because of economic reasons, jobs and all that, you know. But if you've lived together and you have not achieved the pregnancy, then you need to do the fertility checks just to make sure everything is okay.
Okay. So that would mean that ideally women should try to get pregnant before they're 35. Anything after 35, then especially for the first time. This is what we're saying in essence, right?
I don't know if I would say they should try to get pregnant. They should be concerned if they really want to have children and they haven't been able to do that before the age of 35. At the age of 35, they should get concerned. I think that's the way I'll put it. Because, you know, women are getting married later. All right. So not to say, oh, everybody go out there now and start having babies. But if you are getting married close to the age of 35 and you haven't had a child before, then just use that age 35 as a benchmark to say, if this hasn't happened by this age, I will definitely go to have a screening at a fertility center.
Okay.
Yes.
So let's move on to the next thing that I would love to ask you. What is the process like? Say a couple now have decided that, look, we need to go seek more help, and they come to you. What's generally, I know to each his own, but generally, what's the process like?
Okay, so I'll say what we do at NISA. I know different hospitals will do different things. First of all, we want to make sure the woman is healthy because she's planning a pregnancy. You know, a lot of women's only contact with doctors is when they go for antenatal care. So you don't be surprised the lady coming for a fertility check, for instance, has never seen the doctor to have a general checkup. So the tests we do involve a general checkup, okay? And then we do check specifically for fertility. So we do a lot of blood tests that cover this, okay? And then we also check, you know, she would have scans to make sure her womb looks okay, to make sure the ovaries look okay. She has tests to make sure her fallopian tubes are working well, all right? The man also will have, maybe not what we don't do such a thorough health check in NISA, just general screening. And then we also look at his semen analysis to make sure that the semen looks okay. When we have those results back, then if there are any health issues we need to tackle, we tackle. For instance, you may find out some clients are hypertensive, some are diabetic, some have hormonal disorders. So you treat all that. And then if there's anything specifically fertility related, then you offer the fertility treatment to match whatever has been discovered.
So typically, how does, let me rephrase this. Diabetes, hypertension, can they be major factors to the man or the woman being able to fertilize the other, if it's a man, fertilize with his sperm, if it's a woman, to be able to conceive?
Strictly speaking, no, but it can affect their health if they get pregnant, okay? Sometimes the medication that they take for these conditions can affect their performance. For example, diabetes for some men, it will come with some erectile dysfunction. So that can affect him in that way, And then, if even the diabetes in a woman may have other issues that will also affect, show that she has some hormonal issues. So that in that way can affect. But strictly speaking, if somebody is hypertensive or diabetic, that does not translate to a cause of infertility, strictly speaking.
Now, another question. A lot of people feel, when you just see a couple go for IVF, you'll get pregnant. So the question is IVF a sure banker?
No. Now,
and what are the things that could affect the success or failure rate of IVF, if there are?
Okay, let me just correct something, okay? When you come to a fertility facility, what we offer, I will say we, because I'm speaking on behalf of fertility specialists, is assisted conception, okay? So your treatment or your offered treatment depends on what is wrong. For some people, they may just need education, okay? Some people may need tablets. Some people may need procedures done. Then some people will now need IVF. But generally, people just say IVF, IVF. What IVF means is in vitro fertilization. The I stands for in, the V for vitro fertilization. That is fertilization, the meeting of the egg and the sperm is done outside the body. But that is not the only thing that assisted conception involves. For some people, they may have insemination. For some people, we just need to induce ovulation, time their intercourse. So not everybody needs IVF. Because you have patients coming and saying, I need IVF. Not all of them will need IVF, okay? IVF proper, what it entails is, if for instance, for whatever reason, the eggs and the sperm are not meeting, and, because when the egg and sperm meet, what you have is an embryo, and the embryo is not getting into the womb to be implanted and become a pregnancy, then that is when you need IVF. If you find out reasons that are stopping this from happening. IVF doesn't always work. I know patients are not always happy when you tell them, but factually speaking, it doesn't always work. It depends a lot on the age group of the patient, okay? So for the younger women, and sadly, when you see age, I always refer to the woman because the age is really tied to the woman, okay? For the younger woman, her chances of IVF working are in the region of 4 to 5/10. So if 10 women have IVF done, 5 will probably get pregnant. 5 will probably not get pregnant. So that's why people repeat IVF over and over. Now, if the woman is older, if she's in her 30s or even in her 40s, the success rate now lowers. So you're talking of 1 woman in 10 getting pregnant or 2 in 10 getting pregnant. But you see, if you go on the social media, on the news, you hear people boasting of IVF results of 80%, that's 8/10. They're not being factual. Because everybody has different problems. If you do a little Google search and search in the UK, in the US, you won't see those figures. If someone is telling you that the success rate in my clinic is 8/10, then such a person also has to add the age of his clients. So if his clients are all in the age range of 23 to 28, maybe he can get a success rate close to that 6 or 7/10. But if the age range of his clients go from 20 to 40 plus, there's no way he will have that success rate. So that's why I come back to that age 35. So women have to come in early. Another thing women have to know, if you've done an HSG, okay,
what is HSG?
So it's a hysterosalpingogram. What most fertility patients know it as, that painful x-ray that women do, because it's quite uncomfortable, to be honest. If you've done one and they tell you your tubes have problems, what I would advise you as a gynecologist and as a woman is to proceed for fertility care. It is not to mill about, because IVF works beautifully for women whose tubes are not working properly, because the tubes is the road where the egg and the sperm meet. So if your road is blocked and that's your only problem, then IVF works beautifully for you. But sadly, what we find out is that women keep having funny procedures to flush the tube, to wash the tube, to repair the tube, and age is catching up on them. Then they show up to the fertility clinic when they're 40 plus, and we start telling them, look, your chances of success are not so good, and they're not happy. So my own advice is, number 1, age 35, go and have your fertility check. Number 2, any story concerning your tubes not working properly, go to a fertility specialist and have it sorted out, because chances are IVF will be easier, cheaper, and will work.
Let's talk about some, because I'm very, very particular about the solutions. The things that you're talking about, Dr. Yahaya, they are available at NISA, right?
Yes, they're available at NISA Kaduna.
Okay.
Yeah.
Okay. So that's great. Now let's talk about some of these things that you talked about. You said it's not everyone that needs IVF, and you just talked about the HSG.
Yeah.
What other procedures do you have there?
So let's start with the simple one. Sometimes a woman's problem is she's not ovulating. Okay, that is, ovulation means you release an egg from the ovary. Now, when a woman ovulates, 14 days later she gets a period. So that's why your periods are regular. You should get a period every, let's just say, 25 to 30 days. Okay, so that's like translates to every month. Some people will say, oh, I got a period beginning of the month and end of the month. It's not a problem. If you count from the day you start one period to the day you start the next period, that is your cycle length. So as long as your cycle length remains within the region of 25 to 30, so every 25 to 30 days you start a new period, you're fine. Okay, so when a woman ovulates, 14 days later, she menstruates. Once you find out that you are not menstruating every 25 to 30 days, that is probably because you are not ovulating. For such women, when they come in and we investigate and we find out your problem is not ovulating, we find out why you're not ovulating.
Hold on, doctor. Do women like that, do they still see blood as period every month?
That's what I'm saying. They wouldn't see it monthly. So you hear someone sees a period in January, the next period comes in April, the next one comes in maybe October. So she has like 3 periods a year.
So what about those that see it less than 25 days?
Those that see it may have, I mean, if the shortest your period length should be is 21 days, that's still acceptable.
Okay.
But if it comes more, then you're having intermenstrual bleeding, then we need to find out what the reason is. For that. Okay, so if you're having few periods, you're not getting up to 11 to 12 periods a year, you're probably not ovulating regularly. So it's going to be difficult for the sperm to get the egg because the egg is not coming at a regular interval. So for such women, what we do is to induce ovulation, and that may be all they need. So we induce ovulation. We now know, because it's like we've taken control of your ovulation. We now know when you're ovulating. We now tell you, oh, this is the best time to have intercourse. You're probably ovulating now. So such people don't need IVF. Okay. For some people, you need to go a step higher. You control the ovulation. Okay, and then you actually get a sample of the semen and you push it in at the time when you know she's ovulating. So that's what we call insemination. So the first one, we time the intercourse. We advise you when to have intercourse. The second one, we inseminate. We actually ensure that the sperm gets in there. Okay. But remember, for such people, we need to have evidence that the tubes are working, the fallopian tubes. So that's why they would have done the HSG that shows the tubes are working, because we are relying on the sperm to travel through the tubes to meet the egg that we have made sure we prepared there. So the next step now will be the IVF proper, where we now give you medication to make sure you have many eggs. We go in there and extract those eggs. We get a sample of your sperm. We meet them in the lab. That's the IVF.
Right.
We get them fertilized. Then we put them back into your womb, and then we hope that it becomes a pregnancy. It implants. It's just like sort of like planting corn. You put it in the soil. You cannot guarantee it's going to sprout. So that's how it is with IVF. So you have a 4 in 10 chance of it sprouting, generally speaking. Okay. Something else people need to understand when you have assisted conception, whether you have timed intercourse or insemination or even IVF itself, whatever happens to a regular pregnancy can happen. So people can miscarry. Okay. People can have problems during pregnancy. So the fact that you get pregnant with IVF, sadly, there's no guarantee that you're going to have a live baby at the end. The same way when you get pregnant naturally, there's no guarantee you'll have a live baby. I mean, you'd go for good antenatal care, we do everything, but we cannot give you guarantees. Because what I found out, our clients, they want guarantees. They want to know that as long as I've paid this huge sum of money, I will definitely walk out of here pregnant. And if there's any message I want to get across this evening is that if a fertility specialist is being honest with you, they can't give you guarantees. It's not pleasant to hear, but that's the truth. You cannot give guarantees.
Truth trumps every other thing because it readies you. Do you counsel people before you start this process?
Yes, we do. So, I mean, like what I do, this is what I do. I've had a client say to me that it's like you're being negative. I said, I'm trying not to be negative. I'm trying to tell you what can happen. Because if by the time we do the treatment and it doesn't work, you're not in a state to hear what I'm saying now. So let's have all the discussions now before we even start, so that we sort of manage your expectations. So, I mean, I guess every doctor has his own style, but my own style is know what you're getting in for. So I'm going into this thing, there's a 4 in 10 chance that it will work, but I do have a chance. I mean, sitting at home, nothing is changing, but as I'm here, I've sort of increased my chances of getting pregnant, and then let's see what happens. So we give you, you try and obey all the rules, you do all you can, and then you hope and you pray. But what people can do to maximize the chances of success, as I said, is to come in early. Okay, and then also once you have tubal problems as a woman, so 2 things I would say. if you have been discovered to have problems with your tubes as a woman, go straight to a fertility specialist. If you have been told that your sperm count is low as a man, I would advise you to do the same thing. Because the issue of low sperm count is, how low is low? There are men that have low sperm count. There are men that have no sperm count. So for low sperm count and no sperm count, you definitely need to see a fertility specialist. And the thing is, if you have an ongoing condition that is making your sperm count bad, it's probably progressing. So the more time you stay at home and take all these funny herbs and stuff that people take, you're just making the chances of even the IVF working more difficult. So you come in early and let the fertility specialist see you. Now, something that a lot of men do is that they go to see the urologist who does procedures on them. Now, not to castigate my colleagues, because obviously urologists know what they're doing, but some people, after that, the sperm count even gets worse or it disappears. So I would say, if your sperm count is low, why don't you see the fertility specialist, see if they can work with that low count before you have any surgical procedure, so that if it can be sorted, or if your wife can get pregnant, then that's okay. Then if you go to have a procedure and it makes things better, all the better. You understand? But you have people that will say, oh, my count was low and then I had this procedure and then my count went to 0. We can't manufacture sperm, we can't manufacture eggs. So seeing the fertility specialist wouldn't change anything. So before you have any intervention done, make sure a couple has gone to see a fertility specialist, you know, and tells them, you know, what the issues are, and then you move on from there.
Can you work with a woman who's got fibroid, who has, you know, the condition of having fibroids? Can you work with people like that?
You can, because it depends on the location of the fibroids. So what IVF, you know, I told you that you put the fertilized egg, which is the embryo, you put it back in the womb. As long as the lining, the inner part of the womb, is beautiful on the scan, you can see it entirely, you can always put the embryo there. Not everybody needs to have something done to their fibroids, because unfortunately fibroid surgery sometimes may make things worse, because some fibroids are so close to the lining of that womb that in the process of removing them, some damage is done to the lining. Now the lining is something that cannot be recreated. Once it's gone, it's gone. So I would say,
wow, the lining of the womb,
yes,
cannot regrow.
No, it can't. Essentially it cannot. So it's important that before you start having manipulations done, you know, you see a fertility specialist. There's a condition, I don't know if you've heard of it. It's called Asherman syndrome, where the lining is scraped off. So that usually happens when people have D&Cs. That's why they say, oh, you had a D&C, you can't get pregnant, because D stands for dilatation, then C for curettage. Curettage means to sort of like scrape. So sometimes in the process, some people are too, what word will I use, vigorous in the scraping, and they scrape off the lining. When they scrape off the lining is what builds up, is where the baby implants or the pregnancy implants. If it's gone, it's gone. So such women will end up with not having periods or having extremely scanty periods after a D&C, and it's difficult to get that lining to regenerate. For some women, sometimes a procedure to help regenerate works, but it doesn't always happen, you know. So fibroids, be cautious, find out, you know.
Do you have services like that where you can regenerate, try to regenerate?
A general gynecologist can do that, you know. What I'm saying is that, in essence, let's not always opt for the surgical option. So sometimes I would say, you know what, why don't you see a fertility specialist, see if they can work with your womb with the fibroids in it. And then, you know, afterwards...
Because many times we just keep hearing, okay, this person has fibroids, cannot take in. That's why I asked the question, can you work with women who have fibroids?
Fibroids per se don't cause infertility. Per se, I mean, in the rare instance that you have fibroids at the corners of the tube, it can, you know, contribute to your infertility. But per se, the fact that you have fibroids shouldn't stop you from getting pregnant. It can make pregnancy difficult, but it shouldn't stop you. Women have had babies with fibroids, you know, so it shouldn't. So chances are, if a woman has fibroids and has difficulty getting pregnant, she also has other issues going on, probably tubal or maybe ovulatory or something else, or maybe it's even the male factor. You know, the male factor is something that is underlooked. If you notice at fertility clinics, you see women, you hardly see men come. So that's why I'm saying that if you've lived together as a couple for a year, you've had regular sexual intercourse, you've not used any form of protection or family planning, both of you should have testing. The man should go for a sperm test and the woman should do her test also. If the man is told that his count is low, then he should follow up in the fertility clinic, find out how low is it and what can be done. I mean, the WHO standard for romance count should be 15 million sperm per male, okay? So if your count is lower than that, then something needs to be done. You can now understand why there's a delay in getting pregnant. Some men's sperm counts are less than 1 million. So such people, their only medical option will be IVF.
Is there any way that you can know what a man's sperm count or the picture is like just by how he ejaculates? You know, is it something that you can tell? Because, you know, I've heard men say, when I ejaculate, I mean, there's a lot. It's all over the place.
The quantity doesn't matter. Remember I told you that you count the sperm per mil, okay, per milliliter. So if you want, you can produce 300 mils of semen. If the actual count of sperm per mil is not up to 15 million, that's a low count. So it's
and it's not something you can tell by just looking at it.
Oh, definitely not. You have to use a specialized microscope to see the sperm. Okay, so if you see a picture of sperm that are healthy, sperm count that is semen analysis, rather, let me put it properly, you would see sperm all over the place. You can't even differentiate them. Then you see the picture of one who has a low count. You find one sperm here, the next one is at the corner of the microscope. Without even being trained, you know that there's definitely something going on here. So the quantity of ejaculate doesn't really matter. It's what it contains that is the issue.
Okay.
Yeah.
If you're just joining us, we're talking fertility issues, challenges, factors that affect, and most beautifully, solutions that are available here in Kaduna, particularly at NISA Fertility Clinic. Let's go on a short commercial break, and when we get back, we'll do some more talking. Stay with us. With Jacqueline Adebija. All right, thank you so much for staying with us through that. Time for us to start to take your calls, even though I know there are lots more of questions that I know that I want to ask, but it's time for us to open up the phone line so that you can ask those questions, because I think you are more important. I know actually that you are more important. So at this time, the lines are open, and in between all of that, I'll be taking a look at the WhatsApp and also text messages that you've sent so that I can be asking Dr. Yahaya these questions. And the numbers are 081 40,000 989. Once again, that's 081 40,000 989. Then there's 070 87 800 989. Once again, that's 070 87 800 989. Talking about fertility, its challenges, the factors that affect it, and ultimately the solutions. Talking with Dr. Selma Yahaya of NISA Fertility Clinic this evening. Let's go take your calls now. Hello, good evening.
Good evening, ma.
You're welcome.
Yes, it's Blessing calling from Angola.
Go ahead.
There's a woman I know, she's my neighbor.
Okay.
So she's suffering with this fibroid. They operate her almost 3 different occasions. Up to now, about 10 to 11 years, up to now, she has not took it.
Wow.
So I don't really know.
Okay.
Is that any way that they can help her?
Okay. All right. Dr. Selma will answer that. Thank you for calling. Still taking your calls this evening on the matter that we're talking about, fertility, challenges, factors, and solutions. Hello, good evening.
Good evening, Jacqueline.
You're welcome. Your question, no need for introductions because I do understand the sensitive nature of our discussions this evening. So just go ahead with your question.
I'm a woman of 45 years.
Okay.
I've been married for 6 years, although I have children before.
Okay.
Since I got married, I couldn't take nothing. I have did a HIV like 3 times now.
Okay.
I'm still working.
Okay.
So I don't know how the doctor
Give me
will
to
help
write
me go
down the
through.
questions.
Send me her number so that I will attend the clinic.
Okay. I'm sure she will call out a number by which you can get through to her. You said you're 40 or 45?
45.
45.
Yeah.
Okay. All right. Thank you so much for calling this evening. She will call out her number so that you'll be able to get through to her if you'd like. All right. Still taking your calls this evening. Uh, while we're waiting for other calls, I'll also. Okay, Doc, could you answer those questions? And then, okay, we already have another one, but let's answer some of those questions. Let's take this one and then answer those questions. Hello, good evening. Unfortunately, I couldn't hear you. Still taking your calls this evening. Hello.
Hello?
Yes, good evening.
Hello?
Yes, we can hear you. Good evening.
Hello?
Uh-oh. I think and you're so clear
Yeah, good
over here.
afternoon.
Okay, okay.
Good evening.
Good evening. All right, go ahead.
Hello, good evening.
Good evening. You're welcome. Go ahead.
My name is Mariam. I'm calling you from Banawa.
Okay.
I want to come to the hospital.
Okay.
I've been married for 2 years
Okay.
and I've been staying with my husband. No issues.
Okay.
So I want to come to the clinic.
All right. I'm sure
The address, I don't have the address. I don't have the address because I just on my radio.
She will call that out for you this evening so that you will be able to get it. Just wait until the end of the program. All right.
I should call at the end of the
No,
program.
no, no, no. I say just wait until the end of the program. She will she will describe the place and also give you a number by which you can get to them. All right. All right. Because we do understand that this is a very, very important topic, especially for women. Dr. Selma, you want to answer some of those questions? Actually, not really questions asking for directions, but could you speak to some of those
Okay, let me just
situations?
talk about the two patients that called in, okay? So for the lady who has a neighbor who has had 3 or so fibroid surgeries, what I would say is that she needs to have a fertility check, okay? I don't know where she did those surgeries, whether it was in a private hospital or in a government hospital. Let me just, little bit of advice. If you have issues, I would say a good place to start is in a government hospital, because in a government hospital, I am sure if you see a gynecologist, it's a proper gynecologist. I'm sorry to say, not to castigate private hospitals. Sometimes the person you see has been practicing gynecology but may not be a gynecologist, because a properly trained gynecologist will know the point at which they will now refer you for specialist fertility care. So I would say let this lady start from the government hospital, okay? I don't know her age, I don't really know the circumstances. And when the government gynecologist sees her, he or she will know what to do. If she needs a fertility care, they'll be able to refer her appropriately. So that's for that.
Okay.
For the 45-year-old woman who's had children before and who hasn't been able to have children for some years now, you definitely need to see a fertility specialist, and then see what your options are fertility wise. Let me just say something by the side now, okay? You see, the thing about having children, yesterday was Children's Day, and I am of the firm belief that children are always a blessing. But something we have to understand and appreciate as Nigerians are, you can have children in many different ways, okay? So some of us are going to give birth to our children biologically. That is, we will carry the pregnancies in our own bodies. Some of us will have other women carry pregnancies for us. So we will have our eggs and our sperm implanted in some other woman's body called a surrogate, and she will carry these pregnancies for us. And some of us will have children who have been born by other women and whose eggs and sperm belong to other people. That is adoption. In all cases, we are parents, okay? It's just that the road through which some of us will become parents will differ. So either you're going to be birth parents, or you're going to be parents that became parents through surrogacy, or you're going to be parents through adoption. And when you see a fertility specialist, all those areas will be explored. For some people, if the womb is damaged, either at birth, because some people have wombs that they were born like that. The wombs were born and they cannot carry a pregnancy. Such people may end up having to have somebody else carry a pregnancy for them, or they may end up having to adopt a baby that has been born by other people who for one reason or the other cannot take care of those babies. But when you yearn to be a parent, you have to be open to these three ways of becoming parents. So that's something else that we need to also think about. Okay.
All right. Quickly, Dr. Selma, a lot of people calling, but I want to ask this question too, because ultimately I think prevention is better than cure in many cases. When you talked about blocked tubes, what are some of the things that we do as ladies that could lead to having blocked tubes?
Sometimes it's not anything you do, it's just the way we are made, okay? So the way a lady's body is made, things go in, you know. So anything that goes in potentially can go in with an infection that can ride up and cause blockage of the tubes, okay? So the male organ, for instance, I mean, men don't sanitize their organs. So even by mere fact of the male organ going in there, you can have an infection, okay? Planned or unplanned. Sometimes tampons, sometimes this douching that people do, you put your hand way up there and you wash, which is totally unnecessary, which a lot of us have been taught by our grandparents and great-grandparents to do, but I tell you it's unnecessary. I've said it on this program and I would say it again, wash only what you can see. Anything you cannot see does not need you putting your hand in there to wash. The vagina, which is what you can't see, is a self-cleansing organ. You don't need to put soap in there. You don't need to put salt in there. You don't need to put any herbs in there. They will cause you more damage and they probably don't cause any good. Okay? So things like that, okay? So the infection ascends through the vagina into the womb and goes into the tube and blocks it. Something else that has also been implicated in tubal blockage is appendicitis. You know, you have an infection there, the appendix on the right is close to the tube, and sometimes you may have an inflamed appendix that is silent, for instance. So it goes there and it messes up that area. The tubes are very fragile, so anything can hurt them. Sometimes it's surgery that you have. So you have surgery and the tubes get damaged. Sometimes it's procedures that you have. So a lot of things can cause damage to the tube.
What
then
about
of course,
infections?
yes, of course, the most common cause is your infections, your sexually transmitted infections. The silent ones are the most dangerous. So you have chlamydia and you have gonorrhea. And a lot of women, in half of the women that have this chlamydia and gonorrhea, it doesn't give symptoms. Unlike in the man, where you have, I mean, if a man has gonorrhea, he'll know. But not all women may know, you know. So those are the particularly notorious ones. And people have this idea that, oh, it's except a woman has multiple partners, she cannot have sexually transmitted infections. That's not true. If she has an infected partner, that's all she needs. You understand? So you don't have to have many partners. If your partner has many partners, you will have the you have the effect. Okay? And the test, you know, when you go, because you see women say toilet infection, there's no such thing as toilet infection. It doesn't exist. So all those itching you have is probably candida. You know, you have itching and then a discharge that looks like curdled milk. What was this? Like awara, I think. Yeah.
Yes, like yogurt.
Exactly, like yogurt. That is almost harmless. It's very irritating to have. You have the itching, you have pain, but that doesn't go to block your tubes. Then you have the fishy smelling one. That's bacterial vaginosis. That doesn't go to block your tubes either. So those are the ones that most women complain about and call toilet infection. The gonorrhea and the chlamydia will most likely not give you symptoms that you'll notice, and those are the ones that are implicated. And then of course, women that have
those up from toilet seats.
No, not really.
Really?
Oh, chlamydia and gonorrhea is sexually transmitted. It's sexually transmitted.
Wow.
Yes.
So all these things that we've been saying, toilet infections, there's really nothing like that.
There's nothing like a toilet infection. Some women are prone to bacterial vaginosis. If you notice, it will be just before, around the time of their period, they start getting that fishy smell, you know, and it's something that you keep treating over and over and it keeps coming. Sometimes you have to treat it monthly for 6 months or so. Even the candida, you know, the thrush, you have to treat it for some people up to 6 months before it goes, you know. Those are not the issues. Okay?
So basically, they are the ones that are silent, the ones that we get from active sexual intercourse.
Yeah, if 10 women have chlamydia and gonorrhea, 5 of them will be totally asymptomatic. That's how silent it is. but it's gone ahead and done its damage. And, you know, I mean, like what they do abroad, when you have a new partner, they go for a sexual health screen. So the man is checked, because you see, they are more open about things like that. So you go to a sexual health clinic, he is checked, the woman is checked, they make sure they are clean, then they have unprotected intercourse. But sadly, our African culture, we hide everything, nobody is having sex officially. And then you keep moving from partner to partner, and then you just keep co-transmitting infection. Now, a lot of the tests we do, when they say, oh, I went to the hospital, they did swabs, we hardly do swabs for chlamydia and gonorrhea, because they are quite expensive. They are not your routine swabs you do, and you need to take the tests from the cervix, sometimes from the urethra, and you don't always do that in a woman, and then you need specialized testing to test for them. So what we normally do is, you know, to cut costs in Nigeria and Africa, when a woman comes with any form of discharge, you just treat as if she has chlamydia and gonorrhea. But a lot of women will not take the prescription properly. They may not give their partners. Do you understand? So it's poorly treated. And then that now goes on to sort of affect the womb. So for the single ladies out there, I would say, look, just use protection. Use a condom. It's not about preventing an unplanned pregnancy, is about protecting yourself. If you've made a decision that you're going to go ahead and have intercourse out of the context of marriage, then go ahead and follow up on that decision and protect yourself and even your partner. Because at the end of the day, if you end up with blocked tubes, you feel bad about it, you know. And then, of course, the usual one, they say, she's been having abortion. Having abortions can also block your tubes, in that the process, a lot of them have abortions in places that are not safe. So in the process, you get an infection that is introduced, and then it ascends and goes on to block your tubes. Wow. So those are the many ways in which tubes can be blocked.
Can get blocked. All right. Not enough time when we're talking with Dr. Selma at all, but let's see if we can take just a few more persons before we go, just 2 more persons, and then we'll call it a day. But you have to be really, really fast. Hello, good evening.
Hello, good evening.
Yes, your question, 30 seconds, please.
How are you?
Fine, thank you for asking. Go ahead.
I am Mr. Luca Adwa calling from Rabarido.
Yes, sir. Go ahead quickly, please.
In fact, your guest has spoken very well, and listened to her from the beginning up to this material time.
Okay.
You see, this is our tradition. That's the African tradition.
No, do you have a question, sir? Because I know there are a lot of people.
The question I'm trying to ask,
Okay.
The question I'm trying to ask is, I do not know whether they have specialized areas, like you said, that actually there are clinics where before you marry, they check the husband and the woman.
Okay.
But here you find out that there are a lot of men that actually, I know about 3 or 4, that every blame is on the woman, but it is the men that are having the problem.
Okay, sir.
So I don't know whether there's any way that actually people
places where people can go for testing. All right. Thank you very much for your call, sir. Do you offer testing for people who are especially about to go into marriage? Do you have testing like that can, weigh what is going on fertility-wise with both parties?
It's a bit tricky. The one I say you can do for sure, there are 2 things you can do. I mean, if you have an HSG done, you can tell that the tubes are blocked. So chances are you have problems. And then if you do the sperm analysis, you can tell that he has a low count, for instance. But let me also go back to the definition of infertility. Remember, this is a couple that must have tried for 1 year, because sometimes on paper a couple looks infertile, but if you've not tried them, you can't really go. So that's why this testing before you get married can be tricky. There are only 2 instances in which I will say I'll be a bit concerned. For example, if a couple comes to me and says, we want to test before marriage, I can do the fertility test. But if they have not been having intercourse, I can't say, because I've seen that your tubes are not working well, then you will not get pregnant. Come and do IVF. That would be unprofessional of me. Remember I said, if a couple have lived together for a year, they are not getting pregnant, they've done testing and her tubes have problem, then you go for fertility checks. But if a man has a test before marriage and you see very low counts or no counts, definitely they're going to have problems. So it depends.
Okay, Doc, at this point, I would like for you to quickly, because we have less than 1 minute, to please describe your place for us, and also give a number, if you will, that people could use in contacting you.
Okay, let me just say one thing. NISA Fertility Hospital is not the only fertility hospital. I will still encourage our clients out there, first of all, visit a reputable government hospital, okay? So we are at 58 Yakubu Avenue, okay? That's in Angwarimi GRA, close to Bafra Hotel. And numbers you can call for assistance are 080-9033-2958.
Please call it again.
080-9033-2958. The second number is 0810-921-6584. When you get these numbers, you can come in for a sort of like a chat, because we do that.
Okay.
And then we just generally tell you what's happened, what
to do next.
Yeah.
Dr. Selma, we want to have you back real soon. Here is hoping that people do take advantage of having you on air today to visit you, or like you said, any other reputable hospital.
Can I just say something quickly? Because you know, as doctors, we don't advertise. So I just want to state here that this is not advertising. But having been in Kaduna for 3 years now, a lot of our patients that come in would have done better if they had been seen to earlier. So I just feel that need to let you know things that you have that you should go and get checked, so that they don't keep coming to us too late when we can't really intervene.
Well, truly, in matters like this, the earlier the better.
Yeah.
Dr. Selma Yahaya, thank you so much for coming in this evening. Here's hoping that we get you back real soon, because there are always things to talk about.
There are.
Until next Friday, when we hope to come your way again, do have a pleasant weekend ahead. Stay victorious.